Good morning. Thank you very much to the organizers and the chairs for the invitation to be at this terrific meeting. I have the unenviable task of two positions. One is I've been asked to argue for the status quo when faced against a sexy novel agent, and that is always a difficult challenge in the rapidly moving field of modern oncology. I'm also given the unenviable task of going second after Alison Moskowitz, who did a terrific job and puts me in the position of showing you pretty much the exact same data and asking you to draw a completely different conclusion. So let's see how that goes. So I'm arguing that traditional chemotherapy-based approaches are the optimal approach to inducing remission prior to stem cell transplant as second-line therapy in patients with Hodgkin lymphoma. My only relevant disclosure is Seattle Genetics for consulting, and I probably will not be invited to consult again after this presentation. So you're all well aware of the role of high-dose chemotherapy in the curative setting for relapsed Hodgkin lymphoma. This is the initial randomized trial that took patients with traditional salvage chemotherapy, here used Dexabeam, and for those patients achieving remission, randomizing those patients to either ongoing Dexabeam or high-dose chemotherapy with autologous stem cell support. And what you also see in the gray curve is that those patients who went to high-dose chemotherapy had a higher cure rate, where we cure approximately 60% of patients with relapsed Hodgkin lymphoma. So what we now have to ask is why would we supplant traditional chemotherapy platforms for a novel agent like Brentuximab vedotin? Well, in my mind, it has to do one of a few things. It has to allow more patients to reach transplant due to decreased toxicity when you're talking about a single novel agent versus combination chemotherapy. Or it would have to improve the response rate and quality of remission to get more patients to transplant. Alison beautifully pointed out the essential role of complete remission induction on PET scans to achieve optimal outcome. Or it would, of course, have to improve long-term outcomes, show that you can cure more patients with that approach compared to traditional chemotherapy. So I want to frame our debate based around those factors. So we all know the data, and Alison nicely pointed out a number of studies of traditional chemotherapy. Traditional ICE, presented by Moskowitz, no relation, in 2001, where 86% of patients were transplanted. And the question here is, do we need to really diminish the amount of chemotherapy toxicity related to ICE or related regimens in order to optimize outcome? And here you can see in that initial series, 0% of patients did not reach transplant related to toxicity. Similarly, with augmented ICE, also from Craig Moskowitz, also no relation, 97 patients, 88% were transplanted, 5% didn't reach for toxicity. Mini-beam, GVD, very similar. What we're seeing here is that the reason people don't go to transplant is not because they have undue toxicity related to salvage re-induction therapy. The reason they don't get to transplant is because they have chemo-refractory disease, not chemotoxicity. In fact, by definition, these patients are going to high-dose chemotherapy. They are fit for chemotherapy. So toxicity, in my mind, is not the reason. We can see then, looking at responses, will we optimize response and remission induction prior to transplant using Brentuximab vedotin instead of chemotherapy? Once again, numerous chemotherapy platforms, be it ICE, augmented ICE, mini-beam, GVD, DHAP, IGEV, all of these inducing remissions in over 80% of patients. Complete remissions are the vital tool, although the caveat to the CR analyses is that the vast majority of these studies, in fact all but two, use traditional CT criteria, and we know that there's a lot of residual masses, as you know, that are left behind in Hodgkin lymphoma therapy, so PET is really the optimal way to do that. The one study here that did that is the study that Alison Moskowitz pointed out, the augmented ICE study, where 60% of people achieved a CR. So if we look at the most modern ICE regimen, 60% PET CR after that therapy, the vast majority of people reading transplantation. So I would argue, based on these data, that second-line therapy for remission induction is not an unmet medical need. We have countless, practically, regimens that achieve high response rates and high rate of transplantation, and remission induction is not the primary tool unless we're achieving higher CRs with Brentuximab vedotin. So let's think about Brentuximab vedotin. This is, of course, the registration data you all know in relapse refractory patients post-auto transplant, a response rate of 75%, though only 34%, only a third of patients achieving a CR. And I will point out this curve and try and take a little bit of luster off enthusiasm around Brentuximab vedotin and suggest that median PFS of less than 6 months is not great therapy. And so what you see here is that the median PFS for Brentuximab vedotin in relapsed refractory post-transplant disease is less than 6 months. We see a rapid fall off on that curve. If we look to the right and look at the updated data and look at their outcome in terms of progression-free survival based on their status of remission, you can see that CR patients, just over half of those patients remain in remission 30 months later. However, look at the PR and the stable disease patients. Those curves drop like a stone and they head right to zero. What this tells me is that Brentuximab vedotin in the relapsed refractory setting is very good therapy for a very small proportion of patients as a monotherapy. Only 34% of patients achieve a CR, and only about half of those patients maintain that CR. So I would go into this a little skeptical about whether this as monotherapy is going to be the answer for all patients with relapsed refractory disease. And to this setting comes the beautiful data that Allison already highlighted for you, and I'm going to do a less good job of doing that. I'm just going to highlight a couple of things, that if you look at starting with 46 patients in this analysis, and then look how people did after Brentuximab vedotin monotherapy, only 12 achieved a CR with Brentuximab alone. That's 26%. So with monotherapy, we achieved a CR in a quarter of patients. All right, that isn't a lot. And in fact, 70% went on to receive augmented ICE. Now, in my practice, I use standard ICE remission induction. What that means in the Brentuximab vedotin monotherapy study, 70% of people got more intensive chemotherapy than I give as standard practice. If we look at the City of Hope experience, now published by Ron Chen in BBMT, published online, this was a 37-person study. Allison highlighted this as well. And we see similar numbers. In this analysis, a third of patients achieved a CR with Brentuximab vedotin, but a high proportion of patients did in fact need traditional cytotoxic chemotherapy in order to proceed to transplant. 5 or 14% actually did go to transplant after Brentuximab alone, but they were in less than a CR at the time. We'll have to see how those patients do. Time to event analyses are not available for the study online. Maybe we'll hear a little bit more in the coming minutes on this stage. So let's compare remission induction inducing complete remissions with Brentuximab monotherapy compared to ICE augmented ICE. Well, Brentuximab alone, we have now 2 studies showing that you only induced complete remissions in 26 to 32% of patients, a quarter to a third of patients. Compare that to augmented ICE, it's 60%. How many people were transplanted based on Brentuximab vedotin monotherapy alone? 26% in the Memorial study, less than half of patients in the City of Hope study, compared to 90% about of patients receiving ICE. It seems to me we're inducing more CRs and getting more people to transplant with chemotherapy than with Brentuximab alone, taking away that potential argument from Brentuximab monotherapy in this setting. Now, I think the event-free survival curves from Allison's study are looking very encouraging early on, and she told us that those patients, those 12 patients who achieved a CR to Brentuximab alone, appear to be doing very well on that curve. A small caution and a caveat that I'm sure she would share with me, fewer than half of patients, of those 12 patients, have been followed for longer than 20 months. And so follow-up is short. And so for that reason, I don't think we can really assess durability of those remissions with Brentuximab monotherapy, especially when the N is 12 in looking at those patients. I think we need bigger numbers, and I think we need longer follow-up. Maybe combinations are the better answer, and Allison showed you this nice data presented by Lacase and colleagues of Brentuximab vedotin plus bendamustine, demonstrating, and I would highlight, a high-risk population. Half of these patients had primary refractory disease, and among the patients that had relapsed disease, 10 of those had relapsed in less than a year, making this a very high-risk patient population. She showed you the complete remission rate of 83%, which looks very good, and the progression-free survival with already some treatment failures, but very limited follow-up. So this is not ready for prime time just yet, but we are looking forward to further data. Now, maybe Brentuximab has a role in the relapse setting, in the setting of more of a minimal residual disease state. So how about giving it after high-dose chemotherapy? Now, you're going to hear more about this in the upcoming debate, but the data presented by Craig Moskowitz et al., no relation, showed once again the difference in progression-free survival for those patients who got Brentuximab vedotin as consolidation or maintenance therapy versus placebo. for ongoing maintenance after high-dose chemotherapy and stem cell transplant. And what you can see here is a significant improvement in progression-free survival post-transplant for patients receiving Brentuximab vedotin as a maintenance treatment, as opposed to observation alone. There were fewer relapses in the MRD state post-transplant. This led to an FDA label. We now have a proven role for Brentuximab from a large phase 3 study post-transplant, not pre-transplant. The caveat that I will always state is there was no difference in overall survival in this study. However, 70% of patients who were assigned to the placebo arm did cross over and receive Brentuximab, so I think we need longer follow-up to truly assess that. Further, Brentuximab is likely to move further up in induction therapy, potentially making it less available in the relapsed refractory setting. We have phase 1 combining Brentuximab vedotin with AVD. The ABVD combination led to undue pulmonary toxicity, with very preliminary follow-up data in that phase 1 study from Untitled et al. Showing a terrific progression-free survival. We presented data on the right of a phase 2 study looking at Brentuximab plus AVD in patients with non-bulky limited stage disease, no bleo, no radiation, showing excellent outcomes also at limited follow-up. So this drug may be moving more into the upfront setting and have less of a role in remission induction. So I want to conclude by saying that combination chemotherapy produces definitively higher complete response rates and allows more patients to proceed to transplant than Brentuximab alone. The current data demonstrate that a small proportion of patients, 12 patients in the initial series, will benefit from BVD alone, but we need further study in larger trials and longer follow-up to confirm durability. BV alone already has a role as consolidation following autotransplant in high-risk patients, and it's under study both as a component of initial treatment and in novel combinations, as was already pointed out, in relapsed refractory disease. And to finalize, I just want to say, it's not just me. Here's at least one person who agrees with me. The high response rate to Brentuximab in the second-line setting warrants further studies with novel regimens that contain Brentuximab vedotin as opposed to Brentuximab alone as part of first salvage treatment, which could ultimately reduce the need for intensive salvage, but that time is not today. And that came from Dr. Alison J. Moskowitz. Thank you for your attention.